Hi, welcome back to my channel. This is Rhea, your study buddy for hematology, and today we are going to study megaloblastic anemia. So, overview, what is megaloblastic anemia? So, it's characterized by macrocytic anemia, where the cells are large. There are macroovalcytes in the peripheral blood, and there is a defective maturation of the nucleus. Megaloblasts are found in the bone marrow, and they don't really survive as well as the normal RBCs. So they die prematurely, and what you find in the peripheral blood are macroovalcytes. I'm going to expand more about the lab findings in a little bit, but for now, let's talk about the causes. So what causes megaloblastic anemia? There's two main causes. There's vitamin B12 deficiency and there's folic acid deficiency, or a combination of both. So why is vitamin B12 and folic acid important in the body? These two assist in the synthesis of thymidine triphosphate, which is TTP in short. And thymidine is one of the important nucleosides in building DNA. So if you have defective DNA synthesis, then you have a defective nuclear composition, and ultimately that destroys an immature cell because the nucleus is not as strong as it should be. So instead of having thymidine as your building block for DNA, there's another molecule that goes into your DNA because you don't have enough thymidine triphosphate, and this other molecule is called deoxyuridine triphosphate, or DUTP. So if DUTP is used instead of thymidine, the nucleus doesn't survive well. It fragments during development and it destroys the immature cell. So what is happening? This is the megaloblastic pattern. So since you have anemia, your body tries to produce more by releasing erythropoietin, or increased erythropoietin production. And so with the increased erythropoietin, your marrow tries to make more cells. But since your DNA synthesis is defective, you're using a different nucleoside instead of thymidine, you do make a lot. Okay, there's an increase of progenitors and megaloblastic erythrocytes, granulocytes, and megakaryocytes in your bone marrow, and you will see this. But unfortunately, because they have defective DNA, they don't really survive into the peripheral blood, and so they die prematurely in the marrow, and you still have anemia. And so it's like a never-ending pattern of having anemia, increased erythropoietin, increased DNA or production of blasts and cells, but since it's defective, they don't really get to the peripheral blood. Okay, so hematological features. What are the lab results that you will find in someone that has megaloblastic anemia? So there's a decrease in haptoglobin, an increase in bilirubin and serum lactase dehydrogenase, and increase in serum iron. On the peripheral blood, the MCV is greater than 100 femtoliters, increase in erythrocyte precursors in the bone marrow. There's a decrease in RBC release into the peripheral blood. There's a decrease in reticulocytes, again, because they don't survive out into the peripheral blood. They survive only in the marrow. And then there's an increase in RDW and anisocytosis. It's pancytopenic, so your white count and your RBC count is lower. There's Howell-Jolly bodies, basophilic stippling, Cabot rings, megaloblastic NRBCs, and hypersegmented neutrophils. And hypersegmented neutrophils look like this. That's how they look like. So hypersegmented is when you have more than 5 lobes in the nucleus. So obviously on these two pictures, there are a lot more than 5, and they're a lot larger than the usual neutrophil that you'll find in your peripheral blood. Let's now turn to vitamin B12 deficiency. What is it? What's the source? What's going on? So, sources for vitamin B12 found in liver, fish, poultry, meat, eggs, dairy products, and supplements. And for people who are vegans, they can just take supplements for vitamin B12. Vegetables unfortunately don't have vitamin B12, and this will be a problem in some cases, which I will expand on later. And the recommended intake of vitamin B12 is 5 micrograms per day. This is increased in pregnancy, infancy, growth spurts, and in the elderly. So obviously in pregnancy and infancy, there's a lot of cell division going on, a lot of DNA synthesis going on. So you do need vitamin B12 for this, so you have effective DNA synthesis. Transport and metabolism. So it starts with your food. If you eat, fish, meat, you get vitamin B12 that way. And then it goes into your stomach where the R protein picks it up. And at the same time, the parietal cells of your stomach produces intrinsic factor. Remember this, intrinsic factor is produced in your parietal cells in the stomach. That's really important in vitamin B12 deficiency, which you will find out later. So then it gets absorbed into the duodenum, and the IF binds into the B12, vitamin B12. And together, the intrinsic factor makes it possible for vitamin B12 to get absorbed into the ileum. By the time it gets to the ileum, it's only the vitamin B12 left behind, because the IF actually doesn't get absorbed into the ileum. It's just like a transport thing. Like it needs it to get through the ileum, and then the IF just stays behind and gets dissolved into the body. And then the ileum absorbs the vitamin B12 further into the portal vein. So they bind to transcobalamin 1, 2, and 3. Now let's focus on transcobalamin 2, because 2 is the one in charge of distributing vitamin B12 to the tissues that need it and to the bone marrow for DNA synthesis, and it also delivers the vitamin B12 for storage in the liver. Now, important to note is that the daily requirement for vitamin B12 is pretty low, so a lot of our vitamin B12 is stored into the liver. It takes a while for you to develop the deficiency because of this, because we have a lot of stored vitamin B12 and your body doesn't really demand a lot of it from your diet. And so that's that. What are the causes for vitamin B12 deficiency? So there's a variety of reasons. There's dietary, children that are born from vegan mothers. It's really quite detrimental to fetal development and infancy, so it's highly advised that women take vitamin B12 supplements if they're pregnant and if they're vegan, so that they can provide that for their babies. There's also gastrectomy, which is where they remove some of the IF producing cells, and so you have a deficiency in absorbing vitamin B12 because you don't have intrinsic factor that way. And then there's blind loop syndrome, which is the anatomic abnormality of the small intestine where there is an overgrowth of bacteria in the small bowel. And so since you have a lot of bacteria, they compete for the vitamin B12 and they eat up your vitamin B12. And so you don't have enough for your body because there's competition in your stomach. And there's also the fish tapeworm, which is the Diphyllobotrium latum. It is a parasite and it competes with you on your vitamin B12 by splitting it from the IF, from the intrinsic factor. And so you're not able to absorb them and the fish tapeworm eats it. And it's common in Scandinavian countries. There's also a disease of the ileum, and pancreatic disease also affects vitamin B12 absorption. The most common cause of vitamin B12 deficiency is malabsorption because of pernicious anemia. So what is pernicious anemia? So the major cause of pernicious anemia is a deficiency in IF. You don't have the intrinsic factor. It's really common in Scandinavian countries and Scandinavian descent, English and Irish descent, and it is more common in women. So there's also what we call congenital pernicious anemia, which is the total absence of the IF and other gastric juices. And that's that. So pathophysiology, atrophic gastritis and achlorhydria achlorhydria, which is the lack of hydrochloric acid in your stomach. And atrophic gastritis is the damaging or destroying your parietal cells. So they're damaged, and so they can't produce IF. There's also the genetic factor, which is a congenital form, and it shows up in kids that are less than 2 years old. It is an autosomal recessive disorder. And there's the immunologic factor, which is the autoantibodies. Your body produces autoantibodies against your parietal cells, therefore destroying them, and so they're not able to produce IF. And then 80 to 90% of patients with pernicious anemia have parietal cell antibodies. And so in pernicious anemia, there's just, a defect in the production of IF. There's also the Helicobacter pylori, which is a bacteria, and it does major gastritis and peptic ulcers. This bacteria also triggers your body to produce antibodies against the gastric protein pump, damaging the stomach lining, and so it damages the parietal cells, and it causes gastritis, atrophy, and apoptosis on the corpus mucosa. And so that's that. So all of these reasons for pernicious anemia really boils down to your production of intrinsic factor. If it's compromised, then you are going to develop pernicious anemia. So clinical manifestations of pernicious anemia or vitamin B12 deficiency. There's fever in severe cases, there's loss of appetite, glossitis, which is the swelling of your tongue, there's weakness because it is an anemia, and the thing with vitamin B12 deficiency, pernicious anemia, is that it has neurological manifestations. It actually affects your brain and your central nervous system. And so there's a combined term for all of the symptoms that show up in your nervous system, and it's called Subacute Combined Degeneration, or SCD. The patients also experience early paresthesia and areflexia, pins and needle sensations in the toes and later in the limbs. And then there's the later stage of this is that there's clumsiness and incoordinate gait, and there's severe weakness and stiffness of limbs, impaired memory, and depression. And so that's the odd part about this particular anemia, is that it affects your brain. So now we're going to talk about the lab tests for vitamin B12 deficiency, and I'm going to cover first the Schilling test, because this usually comes up on exams, like how do you test for pernicious anemia? It's a Schilling test. But I heard in the book that it's a hard test to administer, so not a lot of people do it anymore, and so they turn to other ways of testing. But this one always comes up on exams, so let's talk about it. So it's divided into two parts. There's the part 1, where you give the patient an oral dose of vitamin B12 that's radioactively labeled. So the patient takes that, and at the same time they get an injection of an unlabeled vitamin B12. So the reason for the injection is that we are trying to saturate your cobalamin receptors. Cobalamin is another word for vitamin B12. And since your receptors are all saturated through the intramuscular injection, that means if you effectively absorbed the oral dose that's radioactively labeled onto your stomach and out through your urine, that means there's just a dietary deficiency. So you just are not having enough vitamin B12 in your diet. So if it doesn't show up in your urine, that means it's an abnormal result, because that means it didn't go through your stomach, into your duodenum, into your ileum. Remember, I talked about the transport and metabolism earlier. So that's how it should have been. Like, it should have gone through into your circulation, and your kidney should have been able to pick that up, because that's excess vitamin B12 at that point, because all of your receptors are saturated. So that's how you know that it's effectively absorbed, if it showed up in your urine. So if it's abnormal, we go and do part 2. The part 2 of this is the same thing. So you get an oral dose of vitamin B12 that's radioactively labeled, but at the same time you also get intrinsic factor. Okay, so that's the twist. And then again, you get an injection of unlabeled vitamin B12 into your body, into your circulation. And so again, it saturates all of your receptors for vitamin B12. And if effectively absorbed with the IF, it should correct the abnormal result from part 1. And so therefore, it should show up in your urine. And so if it gets corrected because of the administration of IF in tandem with the vitamin B12, that means your defect is a lack of IF, otherwise known as pernicious anemia. And then if it isn't corrected, then there's another reason, there's a malabsorption that's happening that needs to be investigated even further. So that's the Schilling test. And so, for other lab tests, you can do serum B12 level, gastric autoantibodies, blood tests for gastric atrophy, serum cobalamin binding protein, serum and urine methylmalonic acid, and total homocysteine. So since the Schilling test is hard to administer, hospitals now turn to serum cobalamin binding protein. This is a good replacement for the Schilling test. So treatment for vitamin B12 deficiency. So the treatment might require, lifelong therapy, especially if it's already affecting their central nervous system. And so there's hydroxycobalamin and cyanocobalamin therapy with intramuscular injection. So they actually get injected with this stuff. And I think hydroxycobalamin is the preferred treatment because it has a longer half-life. Another treatment for vitamin B12 is just orally administering vitamin B12 to patients. So response to therapy. So response to therapy is that hopefully the first sign is increase in reticulocytes 3 to 5 days after therapy, and then it should increase by 50 to 70%. And then the megaloblastic morphology of the bone marrow will disappear within 24 to 48 hours after therapy. Giant metamyelocytes and hypersegmented neutrophils disappear within 2 weeks. And the therapeutic response may only take 3 to 6 weeks, depending on the severity of the disease. So this one's actually not bad. Your body responds to therapy pretty quickly. And so that's that. Woo! And that's it. We're done with megaloblastic anemia, specifically vitamin B12 deficiency and pernicious anemia. So this video covered so much that I'm just gonna cut it here for now, and then we're gonna do a part 2 of megaloblastic anemia that covers folic acid deficiency and macrocytic non-megaloblastic anemias. Okay, so that's that. I'll see you in the next one. Bye.